Welcome back to Maryland Health Today. I'm Ellen Beth Levitt. On the show today, we're talking about the use of a surgical robot for heart surgery. My guest is Dr. Johannes Bonatti. He's a cardiac surgeon at the University of Maryland Medical Center, and Dr. Bonatti is also a professor of surgery at the University of Maryland School of Medicine. Those robots that we were talking about, it's really interesting how that technology is working and so forth. And you're one of the world's most experienced heart surgeons in using a robot for heart bypass surgery. And I want to ask you about that specifically in a couple of minutes. But first of all, why would someone need heart bypass surgery?
Yeah, a patient who has got blockages of his coronary arteries is the one who needs bypass surgery. There's other ways of treatment, of course, but those are the patients with blocked coronary arteries where the blood flow to the heart is impaired.
How would someone get these blockages?
The patient gets these blockages by accumulation of fat, cholesterol, calcium inside his coronary arteries, and those arteries then get narrow and all of a sudden can thrombose by a blood clot, causing myocardial infarction.
Which is a heart attack?
Heart attack, life-threatening situation.
Could somebody also have pain, chest pain, and that could be a symptom of a
Sure.
blocked artery?
That's the warning sign. The patient gets tightness of his chest, chest pain, and should undergo an examination then, especially when it's on exertion.
Who is at highest risk for blocked arteries?
The highest risk is probably patients who have a family history and some kind of genetic disease that causes elevated blood lipid levels. But other risk groups are patients who are hypertensive, diabetics. Yeah.
What about a history of smoking? Does that
Smoking,
give
of
you
course,
a higher
yes,
risk?
Yes, very high risk.
And people who have a high-fat, sedentary lifestyle, perhaps that might be a risk factor as well. So you were saying that sometimes it runs in families? Because coronary artery disease is very common.
Yes, there are families where you get an accumulation of family members who get coronary artery disease, and they need to be watched, of course.
How is it diagnosed? Aside from having a heart attack.
Sure. You mentioned the symptoms. The patient would experience chest pain and then go to his family practitioner, internist, who would carry out more specific exams like an EKG, a stress test, or an echo. And there you would find some hints that coronary artery disease is present. And then the patient would have to move on to cardiac catheterization, by which you can definitely diagnose coronary artery disease.
Let's talk about some of the treatments. Are there some good medicines for this?
There are. Historically, it has been treated with medication, and you will find situations where there is no other way of treatment. If there is no possibility to operate on the patient or to manage the disease with angioplasty, there medical treatment has its role, of course. I guess most of the cases these days would undergo some kind of invasive treatment.
Really? Why is that? Because sometimes the blockages are just so big, or they take up so much of the vessel that that's the best way to approach it?
Yes, and usually the disease is localized, so that you can either dilate it and stent it, or perform a bypass grafting operation.
And I guess here we see a graphic showing that the plaque builds up inside of the artery, and of course that can impede the blood flow. And with angioplasty, that's a minimally invasive procedure, right, where a catheter is fed up through the arteries up into the heart and a vessel is opened up.
Yes. And the nice thing about it is that during the exam, when the cardiologist diagnoses coronary artery disease, he He can discuss with the patient all the treatment options, and if the patient decides for angioplasty, he can do it right away.
Right. Now, why would somebody be advised to have bypass surgery as opposed to angioplasty? Because bypass surgery is more invasive. Is it dependent upon which artery itself is blocked?
That's one important point. I would say it in a way, the more important the artery, the more surgery you would do. So there is certain high-risk regions like the left main coronary artery where probably surgery is better than angioplasty.
Right. There have been a lot of large-scale studies to show which might be better for which circumstance.
Yes, but also other factors, especially if the left heart chamber, the contractions of the left heart chamber are impaired, surgery is probably advisable.
And when you do a bypass, do you need to take a vessel from somewhere else to divert the blood so that you're bypassing the blockage?
Yes, you. In former times, early on, we used vein grafts from the leg, but more and more arteries are used.
Today?
Today, yes, from inside the chest or from the forearms, the radial artery.
I've heard of the internal mammary artery. Is it safe to take a piece of that? I don't know what that particular artery does, but is that just an extra artery that we happen to have?
Yes, it runs inside the chest. You get two of them, and you can use both arteries for coronary artery bypass grafting. And this is the best bypass vessel you can get. And the nice thing about the internal mammary artery is that you count its durability, patency in decades.
It stays open and
stays
functioning.
open for years, 20, 30 years.
Now, the traditional bypass is done with a sternotomy where you have a big incision. Do you have to break open the breastbone as well?
Yes, this is called, it's a midline incision on the chest. It's called a sternotomy. Of course, you have to divide the bone, but many people would think that this incision is very painful. It is not. As compared to a incision on the abdomen or on the lateral chest wall, it's much less painful.
But still, it takes a long time to recover.
Oh, of course, yes. It takes, say, 2 to 3 months to recover from this sternotomy incision. The good thing about it is that you have a very good overview of the heart. You see all the regions and can operate very comfortably.
Right. But now there's an alternative, and that's where you come in because you use the surgical robot for bypass surgery. And could you explain what the difference is for your patients rather than having this big incision? How many little holes do you have to make?
Yeah. So for a bypass grafting operation, endoscopic coronary bypass operation using the robot, we would have 4 portholes on the chest. So 1 for the camera, 2 for the robotic instruments, and 1 additional one for assisting through the chest.
What would be the recovery time then for patients who have the robotic bypass?
Yes, so with robotic bypass we would count the recovery phase in days or a few weeks, 2 to 3 weeks, as compared to 2 to 3 months for a sternotomy. That's realistic.
What about the difference in the hospital stay?
You can also reduce the hospital stay, at least by 1 to 2 days. And the nice thing is that people would start with light exercise during the second post-operative week.
Which is a lot sooner
A lot sooner, yes.
from regular bypass.
I've seen patients who would go on the mountain bike 2 weeks after the operation.
Really?
Yes.
Is there less chance of complications if you have the robotic surgery?
I would say yes. Complications concerning wound healing are less, bleeding complications, and I think it's also the precision that makes this surgery very accurate and less prone to complications.
Right, because you were saying that when you operate the robot, the magnification is so amazing, plus the instruments are so tiny that are inside the patient, and they can rotate in any way that you need them to.
Yes, exactly. It's the precise movements that you can carry out. It's completely tremor-free work.
How many bypasses can you perform? If somebody needed 2, 3 vessels bypassed, could you also use the robot?
At this point, we can do single vessels and double vessels, realistically. 2 mammary arteries to the left chamber of the heart. Very nice concept, very helpful, and with good long-term outcome. We are certainly working on triple, quadruple vessel bypass grafting, but it will take some more technological improvement, new instruments for exposure of the back wall of the heart. But it is realistic, and we are definitely working on those operations.
There's something else that you can do. Sometimes people are told that they should have a certain vessel bypassed with surgery, but that another vessel could be treated with the angioplasty and the stent put in place. Are you also doing operations where you can have both of these done in the same operating room at the same time, you working alongside the cardiologist?
Yes. This is a so-called hybrid operation. At times when hybrid cars are
are
around,
it takes its name?
and have their benefits. I think this hybrid type of operation also has a good future. It is proven that for the anterior wall of the heart, for the most important part of the left heart chamber, an internal mammary artery bypass graft is, with no doubts, the best option. And if we can place this internal mammary artery graft completely endoscopic, and the cardiologist would dilate other vessels, this is a beautiful concept because it includes the long-term success of the internal mammary artery and the minimally invasive nature of PTCA, angioplasty and stenting. And the combination is a promising concept.
And I suppose that this robotic surgical technique might be good for people who are at higher risk for the traditional bypass with the large incision and so forth. Have you found that to be the case, that you could help patients because the robotic surgery is less invasive, less traumatic, so people who might have be more vulnerable from a health standpoint could withstand the robotic surgery?
This is most probably the case. However, during the early phase of development of this procedure, we didn't extend the method to very sick patients because it was new, innovative, and you wouldn't do innovative procedures in very sick patients.
But what about today?
Today we're going into that direction.
Wonderful. And I guess your goal is to help make robotic heart bypass surgery more the mainstream of surgery, just like for the prostate, the robot is used in a widespread way right now. Is that true?
Sure, that's true. I mean, we are out of the learning curves. We are out of the very early innovative process, and I think it's now the time to bring this into the mainstream of cardiovascular medicine. Of course, yes. And if you mention the laparoscopic cholecystectomy, for example,
the gallbladder removal,
if we could develop a procedure that is comparable to this gallbladder removal endoscopic, then we're fine. Yeah.
Wonderful. Well, thank you so much for joining us. My guest has been Dr. Johannes Bonatti. He's a cardiac surgeon at the University of Maryland Medical Center, and Dr. Bonatti is also a professor of surgery at the University of Maryland School of Medicine. If you have any comments or questions about this program, please send me an email. The address is eblevitt@umm.edu. And to reach Dr. Bonatti or any other University of Maryland physician, call 1-800-492-5538 or visit the website. There you'll find a great amount of health information and see other Maryland Health Today shows. That address is www.umm.edu. Take good care of yourself so we can see you next time for Maryland Health Today.